and it's my pleasure to welcome you all today in this surgical program titled as Innovative Advances in Breast Surgery. We are honored to have such a distinguished gathering of surgeons and experts here. I look forward to a session filled with insight, collaboration, and innovation. Let's begin. It's my privilege to welcome Dr. Sayyida Zareen Raza. She's a general surgeon at Jinnah Postgraduate Medical Center with a special focus in breast surgery. She's a dedicated member of our team. She's a dedicated member of our team. As a co-chair, she has played a vital role in organizing Surgicon 2025, and of course, today's breast session. Beyond that, she has been a passionate driving force behind the Breast Cancer Conference, which has become a landmark event at JPMC over the past 2 years. Her outstanding effort, most notably the Breast Cancer Conference, and yes, this event speak volumes of her vision and commitment to her work. We are honored to have her here today. Please welcome Dr. Sayyida Zareen Raza with a huge round of applause.
Thank you, Dr. Fatma. Bismillahirrahmanirrahim. Assalamu alaikum, all of you. On behalf of Organizing Committee Surgicon 2025 and the Cabinet of Society of Surgeons Pakistan, Karachi chapter, I extend a very warm welcome to the distinguished guests, peers, seniors, and junior colleagues. Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, few days ago, I read a comment that surgery is the name of change, and wisdom is to accept that change. I differ a little. Only surgery is not the name of change. In every field, there are a lot of changes. And wisdom is not to accept every change. Wisdom is to accept the change that is evidence-based. And that's what we have in our mind, and theme is reflecting that. Innovative advances in breast surgery. We are fortunate that we have a national and internationally renowned breast surgeon with us as a chair of this session. Yes, Dr. Shaista Masood Khan, who is the Professor Emeritus of Aga Khan University Hospital. After graduating from Dow Medical College, she secured her FRCS, and she is the one who spearheaded the breast care services at Aga Khan, and she also established the first fellowship program in breast surgery at Aga Khan. She was awarded as Outstanding Teachers Award. She was awarded as the Sathai Award, and a very, very prestigious award of the country, Sitara Imtiaz. Madam, we all welcome you. Madam Shaista Khan, we all welcome you with the thunderous round of applause. Madam Shaista Khan, please have a seat in front. And as a co-chair, a very renowned name in breast surgery, and the name that is really very close to our hearts. Yes, Professor Rufina Soomro. Professor Rufina Soomro, she is serving as the professor of surgery at Liaquat National Hospital, and she has been running breast clinic for past 31 years there with a very remarkable record keeping, really very impressive. And she is also the Dean of Breast Surgery at College of Physicians and Surgeons, Pakistan. Madam Rufina, we all welcome you. Please have a seat there. I see many juniors here. And my dear juniors, whenever we talk about the breast, don't forget that axilla is taken as the part of the breast. If you are asked to examine the breast and you don't examine the axilla, so that is just a disaster. Whether it is examination, investigation, or management, that is taken as the part of the breast. And that's what we have our first talk about the updates in management of axilla. That reflects our theme as well. For that, I will request Professor Rufina Soomro to come, please. Thank you, ma'am. Over to you.
Can I have a slide changer, please? Assalamu alaikum. Thank you so much, Zareen, for your kind words and for inviting me to be part of this conference. Yes, axilla is very important and it plays a very important role as far as breast cancer is managed. It helps us in prognosis and in therapeutic decision making. And if you see, the management of axilla has evolved and changed over the years from traditional axillary clearance coming up to the extreme end of maybe avoiding axillary assessment at all. So we are going to talk about it, and we are focusing more and more on doing less and focusing more on the personalized axillary care of these patients. So we have to have a tight balance between effective treatment and minimizing the morbidity of axillary surgery. So how do we do that? Traditionally, it was the axillary clearance, but it is obviously associated with its side effects. So we have to see whether clinically axilla is positive or negative, and we are deciding about upfront surgery versus a neoadjuvant therapy, and that helps in a lot of decision making. When we are saying clinically axilla negative, it means clinical examination and sonological assessment of the nodal basin, whether there are suspicious nodes or not. So if there are suspicious nodes, we do biopsy. If they are not, sentinel node biopsy is the standard of care. And if sentinel node is positive, we clear the axilla, otherwise we do not. Can we get the slides moving, please? So if the axilla, do we always have to clear the axilla if sentinel node is positive? In this landmark trial, when those patients who are undergoing breast conservation surgery, and thereby it will be mandatory for them to have radiation therapy, if up to 2 nodes are positive, then can we avoid axillary dissection? And this trial divided these into 2 groups. In one arm, they got the radiation, and other arms, it was the axillary clearance, and there was no difference. So we do not have to clear axilla if they are going for breast conservation surgery. I think this slide is not moving. Here, it is moving there. Can we help? So there was no difference in the overall survival. When we started doing that, is it that we have to always see whether we have to clear in all the patients' axilla? There was Amaros trial which said if there are even more nodal burden, and in one arm we cleared the axilla and another arm we did radiation therapy, there was a statistical no difference in local control and overall survival, 5-year survival. So even we can give radiation to these patients. But when people started dissecting sentinel nodes more and more, they started seeing even tiny microscopic foci in the axilla. So it is microscopic when the nodal deposit is 2 millimeter and less, and isolated tumor cells when the focus is less than 0.2 millimeter or 200 cells in a field. So does that small nodal burden make a difference? So in these two trials, whether tumor size was 2 centimeters or 5 centimeters, there was no difference. So in overall survival and local controls, we don't need to clear the axilla with micrometastatic disease. Can we avoid axillary surgery altogether? The two trials, sound trial and eczema trials, prove that in sound trials, if on ultrasound, axilla does not have suspicious nodes, and up to T1 tumors, mostly they had, about 87% were T1 tumors. And if that patient is going for breast conservation surgery, we don't even need to do sentinel node biopsy. This is published. And but one have to be careful that if pathological information does not affect the patient's ongoing subsequent oncological management. And in SEMA trial, the nodal size, the primary tumor size was even up to 5 centimeters, and they had the similar results. So if thorough assessment of the axilla by a good sonologist is very, very important to take these decisions. And these are many other studies which have proved this, but with the promise that subsequent axillary assessment is not affecting the oncological decision making. So what about those patients where axilla is positive? Traditionally, yes, axillary clearance had been the standard of care. But nowadays, there are many indications of starting neoadjuvant therapy, but we should be cautious that this does not have a survival advantage, and the response to the systemic therapy is molecular based, maximum seen in HER2 positive and triple negative breast cancers. It allows down staging of the tumor and axilla, and we can do the minimal surgery rather than mastectomies and axillary clearances. When we are giving neoadjuvant therapy, we are not seeing PET-CR in breast, but we are seeing significant number of PET-CR and axilla as well. And as expected, this PET-CR is seen more so in patients who are HER2 positive and triple negative breast cancers. So if these patients are getting PET-CR, why are we doing axillary clearances? So once the main issue with the post-neoadjuvant axillary assessment and doing sentinel node biopsy was the false negative rate is very high. Accepted false negative rate is 10%. And if you see that it was overall, these are the three major studies, it was above 10%. But when more and more sentinel nodes were removed, especially 3 sentinel nodes, then the false negative rate came down to an acceptable range in all 3 studies. So if we are doing sentinel node biopsy after neoadjuvant therapy, it should be dual tracer and 3 nodes should be removed. If on frozen section or otherwise there is a pathologically positive nodes, then we can do axillary clearances. What about targeted axillary dissection? In that, to minimize or the false negative rate, that positive nodes which were there in the first biopsy, if somehow we can put the image guided marker there and retrieve those nodes along with the sentinel node biopsy, that decreases the false negative rate. And there will be more scientific and actual assessment of the axilla. So this is better explained on this diagram, that blue are sentinel nodes, these are non-sentinel nodes. If sentinel node is positive, then we can assess it. But here the sentinel node has turned negative. This suppose was the node which was biopsied. If we remove that targeted node which was biopsy proven pathological, it will be a more appropriate assessment of the axilla. And in this study which was seen, that if we remove targeted node along with the sentinel node, because sentinel node may or may not be a targeted node, and up to 25% of the patients, our false negative rate goes down. And even if alone the targeted node is removed, the sentinel node goes down to an acceptable range. But when people started seeing that at this point in time, If micrometastasis was included, the false negative rate came down, otherwise it was above 10%. So till then, it was accepted those patients who have residual micrometastatic disease in the axilla, unlike the upfront surgery, axilla should be cleared. And that was the standard of care. So we remove clip node along with the sentinel nodes. So there are many ways to localize that. You put a clip in the axilla before you start the neoadjuvant therapy and localize and make sure even imaging of the node that you have really removed the clip node. Can we avoid axillary assessment? Yes, we can avoid in DCIS, provided it is not a palpable DCIS and microcalcification does not extend beyond 5 centimeters. In patients who are undergoing contralateral prophylactic surgery, in genetic mutation patients, or old patients with T1 tumors with clinically negative axilla. Does the size of nodal metastasis matter after neoadjuvant therapy? This study was done to see that. And if you see that, those patients after neoadjuvant therapy, if those who had isolated tumor cells, and we have already defined that, there was no disease in the residual axillary basin when they were cleared the axilla. However, those patients who had micrometastatic disease, 12% had it, and those who have macrometastasis, 37% of the patients have it. So can we avoid axillary dissection in these patients with isolated tumor cells? Yes, we can, but we have to be little more cautious because hormone receptor positive, lobular histopathology, multifocality, T2 tumors, they do increase slightly the risk of having residual disease in other tumor beds. To specifically address the issue of isolated tumor cells, OPBC study looked retrospectively their patients with isolated tumor cells, and this was done in 62 centers in 18 countries. And when they looked at it, only 2% has the recurrence rate, and there was no survival. So I think this study from this large center concludes that those patients who have isolated tumor cells after neoadjuvant therapy, we may avoid axillary dissection in these patients. This is particularly about isolated tumor cells. What are the ongoing trials we have? The ongoing trials to whether really we have to clear axilla in all the patients, or can axillary lymph node dissection be replaced with radiation therapy? So this was the few studies that we have pointed out. One of them is a TAXI trial, which is called not targeted, tailored axillary dissection. In tailored axillary dissection, yes, you do a selective sentinel node biopsy, and you also remove palpable pathological axillary nodes. It was the mandatory, but it was encouraged to have the tumor node which was clipped to be removed. And when it was done, see if those who have a residual positive nodes, dividing into two groups, axillary dissection versus no axillary dissection. And those who have axillary dissection, they will just get the regional nodal irradiation, and other arm, if they have positive axillary nodes, they will just be getting regional nodal irradiation plus targeted axillary radiation also. And then this will be followed up in TAXI's trial. And in this study also, here in TAXI's trial, the patients were taken with or without neoadjuvant therapy mixed. In this trial, they have selectively picked up patients who have undergone neoadjuvant therapy, and these were both palpable N1 disease. And again, these patients, where we are avoiding axillary surgery, they will get regional radiation therapy to the axilla, and regional radiation therapy, and those who are going under axillary clearance, they will just get the regional radiation. And we will wait for these trials to see the efficacy of radiation therapy, whether that can match with the axillary lymph node dissection. And this trial is looking at the same thing. Those who have more than 2 positive sentinel nodes, they will go standard axillary clearance. And those who have 1 to 2 positive nodes, they will again be divided into radiation therapy along with or otherwise axillary lymph node dissection, and then we will see the results. So all these 3 trials are comparing even in those patients which have 1 to 2 positive residual nodes positive, can radiation therapy match with axillary lymph node clearance? Because we have seen that there's little more lymphedema in patients who undergo axillary lymph node dissection versus radiation therapy. And can we avoid? We were talking about avoiding axillary assessment in patients who are going upfront surgery. Now, can we avoid axillary assessment at all in those patients who have undergone neoadjuvant therapy? And these 2 trials have specifically targeted patients which have good response to systemic therapy. And they have selected HER2 positive and triple negative breast cancers. And those patients, they are looking at those patients who have good clinical response. They have selected N0 clinical patients that start to begin up, not node positive patients. And they underwent state-of-the-art standard neoadjuvant systemic therapy based on their biological markers. And if after neoadjuvant therapy on MRI, they have a good clinical response, then these patients will be subjected to assess axilla or not to assess axilla. So these patients will be then divided into 2 groups, and in one group to assess axilla and other groups to have a sentinel lymph node biopsy and comparing the results of these 2 groups. On the other hand, this trial is looking at also these patients, those who have a PET-CR, they will wait for it. Those who have a PET-CR in the breast, wait for this, and those who have achieved PET-CR in breast, then they will not assess axilla, and those who have a residual disease, pathological residual disease in the breast, then they will do a sentinel node biopsy in these patients. So if you see from where we started, from traditional axillary lymph node dissection to sentinel node biopsy, and sentinel node biopsy doing upfront versus sentinel node biopsy doing after neoadjuvant systemic therapy, avoiding sentinel node biopsy in patients with upfront surgery, and now we are thinking of avoiding even sentinel node biopsy who have undergone neoadjuvant therapy. So there's a complete paradigm shift in the management of the axilla. So generally, the de-escalation is becoming a rule in the axillary management, but it has to be taken cautiously, and it has to be discussed in a tumor boards, and this patient management should be taken accordingly. So I think I would just like to summarize this. Okay, those patients who are clinically negative and are undergoing upfront surgery, they should be given sentinel node biopsy. But here, if there are 3 nodes positive, they should undergo axillary clearance. If there are 1 to 2 nodes positive, as we have seen in Z11 trial, they can go get the radiation therapy if they are undergoing breast conservation surgery. However, there is a significant change in patients who are clinically node positive. If they are going neoadjuvant therapy and there's a residual disease, yes, they will undergo axillary clearance. But if you see, people are still talking now about those who have a positive axilla, maybe that is the only positive node. So when we can spare axilla in those patients where there are 2 nodes positive, so why not just take that targeted node and sentinel node, if these are the only two, maybe avoid axillary dissection, even this subset of patients. And we as a breast faculty was discussing other day in our meeting. So, and we can avoid axillary assessment in patients who are old with T2 tumor with favorable biology and may not assess their axilla at all. So I think I would like to conclude here that decision about axillary management should be taken as a team with all stakeholders on board, a thorough assessment, and I think when I say team, it means your radiologist on the board and thorough assessment of the axilla, and because that's where the game is changing completely. And we should have the services available to do biopsy of the axilla, to target the axilla, and to take chemotherapy, appropriate chemotherapy, oncologists, radiation, medical on board to take the right decision for the right patients at the right time. Thank you so much. Are we taking questions now? Any questions, please?
Madam, thank you very much. This sound trial is very sound now. And this is, I think, the game changer now. And we don't have to address axilla. But in this your Z11 trial, do you think that if they have taken just only 2 lymph nodes in the sentinel and 2 are also positive, then we should follow them, or what should be the adequate lymph node which should be taken out through the sentinel? And then we say this is inadequate, mean 2 out of 4 is adequate, but 2 out of 2 is not adequate in my opinion. Then should we follow that Z11 at that time?
I think generally, though the rule of 3 applies to post-neoadjuvant setting, but I feel if only 2 out of 2 are positive, then one should retrieve more nodes and have negative nodes on there, although this is not black and white written in guidelines. But this is just individual perception that if there are 2 nodes positive, I'll definitely try to take more nodes and be absolutely sure that these are the only 2 positive. And in that, where we are doing now, when we are targeting in upfront surgery, targeting the biopsy proven nodes and sentinel nodes, I think this information will be much more useful in managing this site of dilemma. Thank you so much.
Thank you very much for your enlightening talk. That was evidence-based. And my dear juniors, you can see that this is not one size fits for all. We have to tailor the management as per the requirement, but that must be evidence-based. And you also have to recognize that the management of breast cancer, it is not the one department that is involved. There are so many specialties that are involved in the breast cancer management. That's what our next talk is. Yes, we have to see the role of MDTs, for which we have a very distinguished speaker who is a renowned radiation oncologist. He is the professor of radiation oncology at Aga Khan Hospital, and he is also the chairman of transdisciplinary education there at Aga Khan Hospital. He was trained abroad at Ireland, and he came here, joined Aga Khan, and he is there for past many years. And he has 169 papers and 22 books to his credit. Sir, we welcome you. Please, a round of applause for him.
Thank you very much. Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. So, very brief talk, not much, but it's just to discuss few things and that's all. In front of our teacher, I would say, Professor Mujib Chaudhry Sahab and Professor Shaista Khan Sahib. It's always difficult to speak in front of elders like them. It's a joint presentation made by my mentee and my faculty now and resident, Dr. Maria Tariq. She's sitting here in the second row. It's just more like a discussion, nothing else, and few deliberations. Isko na? Thank you, beta. So it will be very brief. It's more for a discussion opening for juniors actually, because inshallah a day will come when we will see tumor boards as mandatory, inshallah. And 100% of our cancer patients in Pakistan will be discussed in the tumor board, like Professor Chaudhry Sahib is already doing in Cancer Care Hospital. We are doing it in Aga Khan Hospital. I hope every single Pakistani cancer patient will have this privilege of discussion. So let's see our own journey and what we have learned through mistakes. Mistakes are the best professor and the teacher. So just starting that, the questions which usually people ask us. This is our own effort inside Aga Khan University, a big encouragement by Professor Shaista Khan. This breast I highlighted because I'm speaking here today. Kal मैं जाऊँगा गायनी में तो गायनी highlight कर दूँगा. So just to please you people here. So these are the boards which we are already doing. Some of them are monthly, but this is our weekly boards which are very strong now. And we are close to 100% penetration now. So 100% of our cases are now discussed. But to be honest with you, I like all these monthly to shift here to fortnightly, like here the lymphoma board and orbital board, and then going up to weekly. So we are working very hard on it and our team is working on it, mashallah. Juniors got all the credit because they collect the cases, they go, discuss and present. This question always comes again and again and again. I was in UK for about 15 years. In United Kingdom, tumor board was not mandatory. It was just like us today. Somebody discussing on the phone, somebody just going to somebody's office and discussing cases as we are doing today. And they were not 100% mandatory at that time. Then they struggled for it and I witnessed that struggle and flux of change from 0% to 100%. So that's why I have the experience which I witnessed and I tried to implement in my own country when I came back in 2005. Again with the team of seniors and juniors. So this is something which is a question is still asked in Pakistan, which is very embarrassing for us actually, because this debate is closed long time ago. This question is no more. But still, because this is asked, so I have to just cover it very quickly. And we wrote a book on this as well, that why site-specific boards are important. We have more publications on this. And across the country, our colleagues are doing it in some form or other. 85% of cancer patients' radiation is arranged by Atomic Energy Commission. Director of Kiran, our friend is sitting here, Dr. Asghar Hussain Asghar. He can tell you, so 19 they have centers. So if a change is going to come in Pakistan, it will come through Atomic Energy Commission. A single authority taking care of so many patients. So if they decide that they will make tumor board mandatory, 85% of radiation oncology cancer patients will get the benefit straight away. So this is something important, a map for us to keep in mind. Very soon, inshallah, Srinagar will come inside us as well, don't worry. That's why I showed it in the map. So this is our city tumor board. This is the only non-institutional, non-territorial, independent tumor board in the world, in the whole world. Okay, we publish that as well. We do it Sunday morning, every Sunday morning. We have done it yesterday as well. Yesterday, aaj ho raha hoga, 8 o'clock. So it's a neutral venue. It's not an institute where we do it in the city center in Numaish. We just got a place there. And we requested to other places as well that they can also follow this and do independent. When I say independent board, that means that it's not influenced by any institution. It's non-territorial. So it's an innovative thing which we have done, and we took the initiative for those patients who have no ownership. When I say ownership means that they are treated in an institute where there is no board. So what is their kusur, what is their fault. So we provided this service to all those poor patients who are getting cancer treatment in hospitals, those don't have tumor boards. And this is going on since 2010, and we have celebrated 15-year celebration only last week. Okay, then the second question comes, do we really have to do site-specific? This is again our colleague, Dr. Rahil is sitting here, and our other colleagues. This question comes again and again that, shall we just do one board? Now, as I showed you, I mean, this is our AKU journey, that we started with one board. So there is no such thing as general tumor board in this world anymore. That's finished. That debate is closed and gone. That's done and dusted. So site-specific boards. So this is actually all evidence-based. We have evidence on this, and then we published our own book, and then we are continuously publishing our things. So I'll say to these juniors sitting here that please come forward for the sake of patients and start publishing, and you will be surprised the citations you will get. We are not going with the primary goal of doing this, but we got it, and I'll show you how. So establishing site-specific, reviews are there. So today I just showing you breast slides. I have slides of each and every site, but I don't want to waste your time because it is a August gathering, people coming here for breast discussion. So this is the things which we have published about this, breast tumor board, again in Baylor, everywhere in the world they are doing. Royal Marsden, where I got my senior registrar training, we were doing it there as well. So everywhere there is a breast board. This is our own publication, a few of them. We have a lot of publications, but this is, we started journey 2016 in JPMA was the editorial. Then we got it again for establishment. Then comes the quality issue that, as Dr. Asim has discussed today, Asim Jafri, that if you are doing something and there is no quality, that's a big issue. So we actually started working on quality parameters, and different aspects of manpower, then management, etc. So on our own publication, we try to address the teamwork. This is again to 2011. So see, this is 14 years old publication. And again, our own city tumor board we published. Until it's published, people were not realizing it. So this is my message to my junior respected colleagues, that publish or perish. If we are not publishing, we are not doing it. We are only saying it. So international, we will never get recognition. So this is again something in clinical oncology, Royal College London thing where we published that multidisciplinary team tumor boards are a lifeline for our cancer patients in LMI. In LMI, see, this is extremely important. Then we published with our Turkish colleagues, everywhere we started. Somehow a surprise happened that my mentees, these three are my residents, who are now faculty, all three of them. Dr. Rabia is with Dr. Fatma in cyberknife and tomotherapy unit in JPMC. Dr. Maria Tariq is sitting here. She is the author of this presentation which I am giving in front of you. So see the citations. We got a lot of citations of our tumor board publications, and that was for our surprise. So many citations of junior residents, and that's because this is a very unique area, especially in this part of the world. So people like to hear from us. We got grants, we presented everywhere, a cultural change we talk about. So Abbasi Shaheed Hospital, just an experiment we have done through the students, and these student chapter have started. Dr. Shabnam and Dr. Rahil is sitting here. And Jinnah Hospital, then again, my own Alma Ata, where I got Dow Medical College, civil hospitals, everywhere we started through the students' help. We call it TEF, Tumor Board Establishment Facilitation Forum. So this is only pictures of only three. Again, a great surname of this hospital where, the third one. Anyway, so this is called the Students' Forum. And surprisingly, the thing which was not able to be done by professors, vice chancellors, and principals of hospitals and institutes was done by medical students. So we can have a clap for our medical students. Across the, they went, facilitated, and it's called TEF. So I request all of you that please encourage your students to go to their chapters and get registered and work with us. So this is started, then again, our awareness. So this is the first paper on the awareness of site-specific MDT tumor boards among final year Pakistani medical students. So Pakistan is a lead Nobody can publish a paper on MDT tumor board without mentioning Pakistani reference. They can't do that. Okay? Because we have covered all across the areas of postgraduate education, undergraduate education, faculty development, appraisals, everything. We have not. So that's why we have 42 Pakistani papers PubMed cited on tumor board. So this is something which we are proud of as a nation. Anyway, so this is again, we took it out, we got some grants and some travel. Wherever the publication was sent, it was accepted as oral presentation, not poster, oral. And the people like to hear from us that how we have established these boards without the help of institution management, just by students, by enthusiastic residents. So this is a unique thing which we have done. So this is our grants where we went with our to different places and presented, and alhamdulillah our Pakistani students were proud of it. This is where this message went in different conferences, professional body meeting like this one today, Surgicon, like this. So we went everywhere. In Islamabad there was a oncological Surgicon, and I was there as well myself and others. And when we have Astro, this is just an example. So wherever we go with the slogan, tumor board saves lives. So this is our slogan, that if we don't discuss patient in tumor board, people will have unnecessary permanent colostomies. People will have unnecessary total laryngectomies. So they are human beings, they are somebody's father, mother, brother and sister, So that is why it is very important for us to understand that tumor board saves lives in Pakistan and everywhere. And then there are some books which we wrote actually on this. This is my own book, but my other authors are sitting here as well. So this is an international publication from us, only Pakistani publications. So we are proud of our juniors that they took this initiative and then they are publishing on all aspects. You can Google it and you will find all these publications. 42 are ours, the rest are other countries. So this is our aim, that we want multidisciplinary tumor board to be 100%. And interdisciplinary process of peer review 100%. Like we are doing it in radiation oncology since day 01, 2005 until now. So 20 years. Global oncology, acknowledgement 116, radiation oncology plans, all gone through peer review, the changes. So I feel very surprised that how people are doing radiation planning without peer review. Because we saw 22% to 79% change in the plan after peer review. And that's what the world is saying. That's what the cross references are there. So we are talking about 30 plus citations of my paper, or Dr. Bilal's paper, of course. Dr. Bilal, Dr. Benazir, who is Dr. Shaista's student actually, radiation oncologist in Canada. Dr. Fatma is sitting here, Dr. Maria is sitting here. So this is all our own original ingenious work, which we have done. Tumor board saves life is our slogan. So I'm just finishing here that please, try to learn team building skills first. It is a pity that in our residency programs, we don't give importance to leadership training. That is why we lost so many years after becoming faculty. I'm proud of my residents that from day 01, I teach them all these skills. Not me teaching them, but we learn together. We are lifelong learners. And that is why with the help of these 20 skills, they can do these type of things. Because they are fully equipped to do that. So I request all the residency program directors that please put all these properly, not just by just doing it for the sake of doing it, but properly, this. And this I have done during my residency in UK. In United Kingdom, you cannot have a CCST unless you do all these courses actually. Most of the time outside NHS, outsourced. So if they can do it, why can't we do it? Why we are second class? We have to be first class. Even we have to teach them. We have to teach them. So this is just an example because you people are involved in breast cancer treatment and others. And there are surgeons, eminent surgeons are sitting there like our teacher Chaudhary Saab. This oncofertility tumor board is started already. We are going to go for AQU as well soon. So this is extremely important because we have cases where fertility was compromised without knowledge of the specialist, and that was because of this. So this will be an innovative thing in the world. We are going to teach the world about this. And I request all of you that please try to understand that these cases are coming to our clinics every day, where tumor itself can cause infertility. Tumor can, treatment like surgery, removal of this, chemotherapy, radiation, and hormone. A 4-year-old girl was referred to me, curable rhabdomyosarcoma of vagina, curable, with full down staging with chemo for radiation. Was just referred to me, that's like this, because I do pediatric radiation oncology. And I said, what will happen to the ovary? Nobody has discussed. She was from interior Sindh, no ownership, just referring like a football here to there and this. So it's a big crime of treating cancer patients without tumor board. It's such a big crime. And it is for the whole country, not for one hospital. So this is what happens that, so we have gone through oophoropexy, mashallah, arranged for them some zakat, etc. And then we gave radiation. Now meticulous, precise radiation is available in the country, both in public sector, in the private sector, both places. But we have to understand that this girl is going to live for 60, 70 years. But she will be infertile without knowing. Nobody will know. Her family will not know. If the specialist doctor referring to us does not know, imagine about the patient and the family. So what is going to happen socially to her? And it's so simple, oophoropexy. A resident can do that, it's not a big deal. And take it out of the radiation field, we can do planning, we can cure the patient. So this is just one example. I finish here, sorry. I took less than the time allocated to me, so questions are later on, afterwards. तो आप ये हमारा स्लोगन ज्वाइन कीजिए इंशाल्लाह. तो इंशाल्लाह उसके लिए आप रोड पे निकले, अभी बाहर निकलेंगे पत्थर लेके. तो ट्यूमर बोर्ड सेव्स लाइफ. थैंक यू वेरी मच फॉर लिसनिंग.
Thank you very much, sir, for your wonderful talk. And as he said, tumor board saves life. But remember, this is just not a slogan. That is basically backed up by the evidence. That is very important thing. And now, as I said earlier, breast cancer management, it is not solo by one specialty. That is by multidisciplinary team. And they work jointly. And we are working together for the success. And that's what our next topic is. The next topic is the role of oncologist in the surgical success. We are fortunate to have with us Dr. Asghar H. Asghar, who is a renowned clinical oncologist. After graduation, he did his master's in nuclear medicine and FCPS in radiation oncology. Presently, he is serving as the director of Kiran, and he is also serving at Maiman Medical Institute. He has lots of books, lots of publications to his credit, and very important thing, a very prestigious award was given to him, a gold medal by the Atomic Energy Commission in 2016. Please applaud, and over to you, sir.
Thank you very much, Dr. Zareen. It's a great honor for me to speak in front of this good forum. And definitely when we are talking about the breast cancer surgery, I think the surgeon is the captain of the ship, because most of the time patients coming to them first, and then they are coming to us. Breast lump can be taken out in many ways. You can go for the chemotherapy and there may not be any lump. Or you can go for upfront surgery, there may not be any lump. But if the breast lump is taken as an axial biopsy, there may not be a lump, but this will be the big mistake by the surgeon, that they have done just only the axial biopsy. We have seen so many patients coming to us that they were having the lump, they went to a surgeon who were not a well oncologically trained surgeon, and they said, "Ye chota sa lean, we'll take it out." And they just took it out, and this was malignant without any biopsy. That was then sent to us. that this was the malignant lesion, no comment on the margin, no comment on the axillary dissection, and this is the best surgery has been done by the best surgeon in that region, and now they have been sent to us, KG, go for this radiation, go for their chemotherapy. So I have tried to focus all these things in this presentation, that if you're going to take out this lesion by surgery, then they are their own indication, upfront surgery. And if you're going to take out this lump with chemo, they have their own indication. You're all surgeon, most of the people sitting over there, they're all surgeon. You know what is the locally advanced lesion and what is the EBC, early breast lesion. Things are changing so rapidly now that when we were resident, there was just only the one thinking that after this surgery, you have to go for the chemotherapy and then you have to go for the radiation therapy, and then if you're hormone positive, you continue with the hormone therapy. Now they say that if there is no lesion, and this is not only focusing on the breast cancer, in the case of the colorectal cancer also, they're saying so many things in this way, that once you have done this upfront chemo radiation, there is no lesion in the rectum, you can omit this further surgery also. Same way coming over here also. Specifically in the field of radiation, if you had done this good surgery, if you've done this good chemotherapy, and there is complete pathological response, both at the level of axilla and both at the level of this your breast level, you can omit the radiation also, specifically to the axilla. Even when it was a clinically positive axilla, or it was a pathologically positive axilla, and you have given the radiation, you have given the chemotherapy, and now there is no axilla over there, no node positive over there, you can emit radiation to this your axilla also. So there are many trials coming now in this way to de-escalate the thing. As Madam Rufina said, the de-escalate the thing in the case of surgery. There are so many things coming that in this that you have to de-escalate the thing in the chemo also, and you have to de-escalate the thing in the radiation also. So I still say surgery is the mainstay of this treatment, and surgeon is the key person. If I'm not saying wrong, there is the captain of the ship. Patient is coming to us, and we send them back to the primary surgeon, that you have to keep that you have to keep in follow up that person, that surgeon who have operated you. I had to ask this my question to Professor Rufina, but I forgot at that time. And I'll put this question to Professor Shaista, because you are the people who are doing so many breast surgery in your whole of your life. Madam, just give me in your comment that what should be the difference, or what is the difference between the surgery done by a very experienced hand, especially the axilla, in there of limb edema, or a surgery axillary dissection done by a surgeon who is not well trained on axillary dissection? So do you think will there be any difference of the axillary, this limb edema development between surgeon to surgeon? This I'll put my question to all of you. So oncologists play its role when surgeon heads up. When surgeons say that this is very locally advanced lesion, T3 plus lesion, 5 centimeter PD orange, axilla is big, 2 centimeter plus lesion in the axilla, then we play our role. We play our role in terms of chemotherapy, and we play our role in terms of then radiation therapy. But in this my presentation, I'm going to tell you something very new now. You being as a surgeon, you can do the same thing what we are doing. Like you can do simple new adjuvant hormone therapy. Just give one pill. उन्हें क्या letrozole खानी शुरू कर दें. I'll show you the evidence. And you see almost same result, but there is some problem with this new hormone therapy. It takes time. You may not be having a good results in the pathologically CR in the neoadjuvant hormone therapy as with the neoadjuvant chemotherapy. This is the reason up till now neoadjuvant hormone therapy is not so standard of the care. But if she is around 50 plus or 70 plus, strong hormone positive, many comorbids, family is not willing for big surgery, you rather sending them to oncologist, you can start your AIs. You start any AIs, I'll show you the data and you see the results. So definitely, I'll not recommend that all this patient, each and every patient should be discussed in this multidisciplinary tumor board, but complicated case must be discussed. Complicated case or case where you have to take the decision. Like if I'm going to plan the neoadjuvant hormone therapy in any patient, that must be discussed because this is something new. But uh, if I'm going to plan for radiation, that must be discussed. If this was positive axilla at that time and now it's negative axilla, then why to radiate axilla now? This must be discussed. It's a standard of care now. We can omit the axillary radiation just to prevent the future edema. So this must be discussed. Complicated point or this something point which needs to be discussed must be discussed. But I'll not, in public sector hospital where you're seeing multiple patients in a one day, roughly 20, 30 new patient per day, it's very difficult for us to discuss each and every patient. But in specialty where you have this much liberty, you have this much time to discuss each and every patient, do discuss that. But at least all those patients which needs some discussionable point must be discussed over there. So, neoadjuvant hormone systemic therapy, you know, it's a standard of care when the T3 plus lesion, positive axilla, PDRA, triple negative, and HER2 positive, they need some neoadjuvant treatment. Just to give the downside, it will tell us how much is the sensitivity to the chemotherapy, how much. If your patient was having Ki-67 high and it's going down with your chemotherapy and hormone therapy, that patient respond very well. This is the PAPI score. I'm going to discuss what is the PAPI score. PAPI score, if our chemo or if our hormone therapy is going to make your patient PAPI 0, that will be having a very good result in terms of the future and without chemo. I'll show you the data that without chemo, you can treat the patient with hormone therapy alone. So, okay, this one is the. This is a phase 2 trial, and I'll show you the phase 3 trial also. That these are the patient, post-menopausal patient, ER strong positive, 239 patient data. And these were the patient were given 3 months treatment of the endocrine therapy, and in endocrine therapy they gave anastrozole or exemestane. Just 3 months treatment. And the second group was given chemotherapy. You just see the response. 64 versus 60, chemo versus endocrine therapy, no difference. Clinical response. Breast conservation rate, rather it was much better in this one as compared to this one. So pathological CR was better in this chemo. This is a one phase 2 trial. I'll show you another thing. If you just see this meta-analysis, this is a meta-analysis of chemo versus hormone therapy. These were the patients you may say may not be fit for surgery, may not be willing for the surgery, old age patient, many comorbids like that. If you just see over here, these are 3 trials published, and if you just see the clinical response was almost same. Whether you give, so this trial showed chemo better, this trial showed hormone is better, and if you just see this prism, average is same. Over here, radiologically same. But the difference was over here. If you just see, pathologically CR was better in this chemo arm. And same way, breast conservation rate was better in this hormone arm. This is the 3 study meta-analysis. This was published. I will not recommend you follow all these things. Up till now, neoadjuvant chemo is still the standard of care. But these were the patients whom you can say were not fit for surgery, whom you can say were not willing for surgery, whom you can say their lesion was strong ER/PR positive. It must be a good ER/PR positive. If your score is coming 3, 4, 5, that may not be so strong positive. And you just see their Ki-67 went down. Their Ki-67 went down, so they checked their PAPI score. And if you just see the pathologically complete response with only one letrozole, just you give 1 year letrozole, your pathological complete response is 17%. So it's not necessary to refer each and every patient to oncologist. letrozole can be prescribed by you all as well. So we can help you in this way that this patient, if is not willing for surgery or is not fit for surgery, you can start this letrozole. Rather than standing to aap usse oncologist ke paas jaएं, they'll give you some better option. So this is a simple option. And you see, we have treated this patient like this. We have seen, we have done so many patients, and we have seen the good responses also. So, same way, if you just see another thing, up till now we recommended Oncotype DX in adjuvant setting. You go for the Oncotype DX in the adjuvant setting, check whether what is your score. If score is 18, you go for the hormone therapy. If score is more than 31, go for the chemotherapy. They did the same thing before this starting hormone therapy, and you saw that when the recurrence score was less than 18, hormone performed better. As compared to when it was 31, chemo performed better. So, if score is less, then that's a good case. So, but Oncotype DX definitely recommended for the luminal A patients, like ERP positive and HER2 negative patient, and Chi-67 should be less than 14%. And if you just see, their response went go very well. It's another trial. This is a phase 3 trial. And in this phase 3 trial was then compared with this chemo also. But initially, they took T2 to T4 C patient, any N, M naught, ER positive, HER2 negative, and 1200 plus patient data. One group was given estradiol alone, second was given fulvestrant, and third was both combination. Just 24 weeks treatment, roughly 6-month treatment. And if you see, if their PAPI score, in PAPI score they basically check what was the initial ERPR status, what is the Chi-67. PAPI score, I'll just let PAPI score mean after this your treatment, if this much lesion goes down to T1 or T2, and not Chi-67 goes down to less than 2.7%, these patient doesn't need any further chemo. So this patient can be treated by surgeon. We can help you in this way. You can treat it at your own. Check their PAPI score. If you're going starting with the hormone therapy, no adjuvant chemo, continue with the same estradiol for next completion of the 5-year and all this. And if there is no PAPI, then start with the chemo and then complete with the hormone therapy. This group was then compared with the chemo also. And if you just see, their pathological CR in all arm was roughly around 1%. Okay, this is the PAPI score 0 being after this your neoadjuvant hormone therapy, T1, T2, node negative ho jata hai, and less than 2.7% ho jata hai, it's a PAPI 0. If your patient achieve this much level, that's a good responding patient. What to do in the post-op setting? Post-op setting, adjuvant therapy, you know very well. This is a keynote 522 trial. We are following this trial standard. In adjuvant setting, if you are given neoadjuvant paclitaxel with the Pembro, you have to continue with the Pembro. And if you are given something like in the form of SISUC trial, your patient has completed upfront chemo, and after upfront surgery, then completed the ACT. If triple negative, we have to give 1 year of capecitabine. This is standard of care. We can help you in this way, in a good surgical success, that these patients need some adjuvant treatment as a maintenance therapy. Specifically for the triple negative patient, they need capecitabine at least for 1 year if they're having the upfront surgery. But as per CREATEX trial, if patient has received neoadjuvant chemotherapy, then you have to give for roughly 6 to 8 months further capecitabine. In the triple negative patient, you have to get better results. Okay, what to do in the RT, radiation, when to avoid radiation. Not all patient needs radiation now, even after the BCS. If you just see guideline has updated now, 70 plus patient, 70-year plus patient, and T1 lesion less than 2 centimeter, you can emit radiation, even after this good BCS. And same way, if they're less than 3 centimeter pathologically pathologically T3 lesion, 3 centimeter lesion, then you can emit radiation. This is the not standard of care, but it's a patient having old age and good ERPR status positive patient. Can we emit the radiation which we use to emit the radiation for the T2 lesion after MRM. Upfront, we have done the MRM. It was a T2 lesion and not, can we emit the radiation? Yes, up till now we can emit radiation, but now the guideline further updated now. Not all the patient needs to be needs emission of this radiation. There is some factor have been added now. If the patient is having the grade 3 lesion, ER negative and LVI positive, and tumor size more than 2 centimeter with these factors, they need radiation. So we can help you in a good success of your surgery. If patient have this type of the feature, they needs radiation in adjuvant setting, even if it's a T2 lesion and not lesion. Now we have we further help your patient in this way, that if you want to have this hypofractionation, we in our residency we started with this protocol, 50 grain 25 fraction. Now we are following 40 grain 15 fraction start beat trial. Now we are further reducing now with this UK fast forward trials 26 grain 5 fraction. Specifically we are not using T3 lesion, but they included the T3 patients also. We are doing for T1, T2 and pathological and not lesion. Strong ERPR positive, this patient needs just 5 days radiation. So if you see any of our patient coming to you with just 5 days radiation, don't get confused with that. We have done all these things in the 5 fraction because this patient was following the criteria of UK fast forward trial. So this is standard now. This is in our books also, because if we surgeon and we are not meeting in the MDT most of the time. So if we're treating any patient in the 5 fraction, it means we have done. Check our treatment summary. What we have written in our treatment summary of the radiation, if you've done all these things in 5 fraction, this is the completion of this radiation. So we are doing, even Shaukat Khanam is doing, big center all is doing now. This was the Z11 trial. Madam discussed that you can emit radiation if you can emit axillary dissection. Or another thing which we can help is genetic testing. In the case of genetic testing, the BRCA positive patient now needs further 1 year of adjuvant treatment. If you're not giving further adjuvant treatment in form of olaparib, this may not be a good surgical success. If you have done a very good job and patient completed the chemo, patient completed the radiation, but it was a BRCA positive patient, then you have to give 1 year adjuvant olaparib. This is standard of care now. In the ovary, this has been recommended without BRCA positive, but in the breast, it is with the BRCA positive. And also another thing which has been now updated, that if this patient is ERPR positive, HER2 negative, T plus lesion, advanced lesion, and node positive, that patient needs abemaciclib in the form of Verzenio for 1 year. So we have to give this further treatment along with the hormone therapy also. So these things are now standard of care. We are doing now, we are recommending patient the BRCA positivity for each and every patient. The question asked in that session that the NGS should be recommended for each and every patient. No. NGS is recommended for highly targetable patients like triple negative patients, strong family history positive patient that needs NGS. So BRCA treatment, patient breast cancer without BRCA may be a big mistake nowadays. We have to check. It's being done in Kiran. It's quite cheaper, just only in 45,000 now. So survivorship, and I'd just like to conclude that this oncologists play central role, but surgeon is a key partner of this whole of this scenario, and they are the captain of the ship. They have to take care of their patient throughout the follow-up period also. So I'll suggest all these big centers which are treating breast cancer patients, they should sit once in a while, like every 6 months or every 1 year, to discuss all these updates. So if this patient coming to me and surgeon not done the axillary dissection, if I'm not well aware of this after this Z11 trial, I'll say, oh, you know, the surgery sahi nahi ki. Go back to the surgeon and complete your surgery. And same way, if my patient is coming from surgeon and saying to me, the surgeon ne kaha ji aapke to shwaएं puri nahi lagi, aap shwaएं puri karwa ke hain. So this need to be discussed in a meeting, that why you have done 5 fraction and why you have not cleared the axilla because of this E11 trial. This need to be discussed just to have the minimum confusion between a patient and us. So thank you very much, and this is my center, and this is my city tumor board by Sarah discussed. We sit together after every alternate Sunday in Zaini Panjwani Hospital, so was ward mein jaye. We'll give you the good breakfast also over there, and we sit over there 8 to 8:30, 8 to 9:30 a.m. alternate Sunday. If you want to be part of this tumor board, just let me know. We'll add you in our group. Thank you very much.
Thank you very much, Dr. Asghar, for sharing with us your experiences backed with the evidence. Now we move forward, and our next topic is innovative reconstruction in challenging breast cancers. Luckily, we have with us oncoplastic and reconstructive breast surgeon, breast surgeon Dr. Lubna Vohra. She is serving at Aga Khan Hospital as the associate professor and the dean of breast surgery, chief of breast surgery there. I would like her to come here and start her talk. Thank you very much.
Thank you very much, organizing committee and Zareen, for inviting me over here to discuss this important topic. Whenever we talk about breast surgery, nowadays, obviously, we talk about breast conservations and partial reconstructions. That's my disclosure, no conflict of interest. And so why we talk about breast conservation more and more these days? Obviously, because in our part of the world, and especially when we talk about this entire region, including India, Bangladesh, Pakistan, Sri Lanka, Middle East countries, Saudi Arabia, we have a lot of young patients. Recently, I had been to Doha for a meeting, and I found that their average age at diagnosis, according to their registry, is like 35. So we have more and more young patients. We don't have cancer registry, sort of a dedicated cancer registry all over Pakistan for our cancer patients. But as per data which is coming from different institutes, including Aga Khan and Shaukat Khanam, we know we have more and more young patients. And as per data published from one of the landmark paper, I think 3-4 years back, from Civil Hospital Karachi, the statistician is talking about that we are going to have more and more young patients in upcoming years as per data and as per registries which are collecting data from all over Pakistan. The other problem is that, obviously, we do not have a dedicated screening program in our country. So we have more and more patients who have bigger tumor sizes presentation. On average, still at our Khan Hospital, we have patients who are presenting like by 3 centimeter, 3.5 centimeter, or 4 centimeter in size when they discovered this lump, and as usual, their comment is incidental discovered breast lump. And you get surprised. Even a fungating tumor, they come up with like incidental discovered. And they just surprise you with that comment and how come a fungating tumor is an incidental thing for you. That's how we are. That's how our population is. Hopefully, like this. So I always ask this question to myself. What I'm doing with my patients and how they're going to live after cancer treatment. Obviously, because of advent of an advancement in neoadjuvant treatments, or the chemotherapy, the radiation therapy, the hormonal therapy, we know they are going to survive long and long, maybe for decades after cancer treatment, like a normal individual. And nowadays, when we talk about breast cancer, it is labeling it as a chronic disease. Patients can survive in the same manner as diabetic and hypertensive can. So that's an important question a surgeon should ask whenever they are treating, what they are doing and how patients are going to live. Half-hearted, with a bad quality of life, with a psychological distress, a flat chest. Maybe they are not that much confident to look themselves in mirror because they have a flat chest on the other side. So that's an important question a surgeon should ask every day when they are treating patients. And when we talk about breast conservations, years and years, decades and decades, and even these days, when I discuss my oncoplastic thing with other surgeons, they always come up with, bhai, ye to breast अजीब सा हो जाता है, positive margins आ जाती हैं, radiation वाले से radiation नहीं करते, recurrence हो जाती है. So these are the pertinent, comments and questions and, the things which is still valid in this era, in this country, in this city. Yes, these are problems. We know these are problems when we talk about breast conservations, the outcome of breast conservation, the texture of breast, the position of nipple, about positive margins, do we need a second surgery? This can be answered if you have done a proper planning. So when we talk about breast conservation as an oncoplastic surgeon or as a breast surgeon, always think about what you're doing and the impact of your surgical procedure in terms of residual tumor, in terms of margins, and in terms of cosmetic outcome. And if you know how to balance your resection with the cosmesis, then you're doing a wonderful job. So, this era, from Holstedian to breast conservation, Holstedian is a historical thing, historical process, but now is a time when we talk about personalized treatment and precision planning. If you're not doing an individualized, personalized treatment for your patients, as Zareen said, हर किसी के लिए एक जूता नहीं है, हर किसी के लिए एक surgery नहीं है, हर किसी के लिए एक mastectomy नहीं है. So you have to think in an individualized manner about your patients as per their stage, as per their tumor, and as per their biology. So whenever we talk about innovative reconstruction things, obviously, in terms of breast, think about the breast size and the tumor size. Think about different locations of breast, where you can encounter a difficult cosmesis or a difficult symmetry, like inner quadrant of the breast, like 6 o'clock of the breast. It's difficult to attend cosmesis if you are doing a simple lumpectomy in these scenarios. Obviously, tumor size, tumor shape, the patient's anatomy, the height of patient, her weight, her breast density, everything is important when you talk about breast conservation. As I said, degree of ptosis, her desires. It's not a case that I, as a surgeon, मेरा दिल चाह रहा है मैं breast conserve करूँगी, आपकी तो यही surgery होगी. You have to discuss the pros and cons and everything with your patient, subsequent treatment plan, the survivorship care plan, everything with your patient. And if she's willing to go ahead with it, then do a breast conservation. This is not your choice. As I said, it's a personalized treatment, so always discuss with patients the pros and cons and aftermath of that surgery. Obviously, when we talk about innovative thing, nowadays we are offering breast conservation even for multifocal and multicentric breast cancer. And obviously, also for those diseases when we have an invasive component with lot of DCIs in the same breast, maybe in the same quadrant or in the 2 quadrants simultaneously. So as I said, precision planning is very important when you offer any form of surgery to your patient, a mastectomy or a breast conservation. How you're going to excise it, how you're going to orient it. Maybe you need an intraoperative pathological plan. Maybe you need your radiologist and radiation oncologist pre-operatively. Whenever I am doing a sort of a difficult oncoplastic, extreme oncoplastic procedures, it's my routine that I discussed my plan with the radiologist, also with the pathologist, and with radiation oncologist. That this is a surgery I'm going to plan, how you're going to radiate this breast. Are you comfortable radiating it? Or maybe when I'm doing a total mastectomy and reconstructions, it's good to discuss with them upfront rather than giving them surprise afterward कि ये है patient, अब करिए radiation इसकी. So that's how the personalized treatment and multidisciplinary treatment takes you to wonderful results. Obviously, patient counseling is important, accurate diagnosis is important. Breast ultrasound, I always give my ultrasound with me intraoperatively whenever I'm doing a difficult sort of a reconstructions or partial reconstructions, so that I can see myself, all the margins, the wires, maybe the clips also, and the tumors also. Then you can precisely excise that tissue without getting extra margins or without getting a bigger resection. So now come to the cases. Simple dermoglandular flap. Most of the time when patients encounter central tumor, many surgeons advise them to go ahead with a mastectomy. Here, only a simple dermoglandular flap, that's called a resortive flap, can be done, and which can save patient's breast without compromising the cosmesis and without compromising their quality of life. A patient who is having a luminal A-type breast cancer, grade 1 disease, you know she's not going to respond to neoadjuvant chemotherapy or the hormonal therapy that much, with mammogram showing a DCIS component and biopsy-proven DCIS with a lot of puckering in that breast. So she was very keen, she was 65 years old, but very keen to conserve her breast. And simple matrix rotation from the lateral side of the breast, because she had a lot of redundant breast tissue or the fat in the lateral side of the axillary folds, that was actually mobilized in a proper manner based on dermoglandular flap, and breast was saved. Now come to the multifocal, multicentric breast cancer. Usually most of the time people, when encounter this type of problems, they explain to the patient there's a high risk of margin positivity. We are not going to conserve your breast primarily because of this multicentric, multifocal disease. Sometimes the comments are the cosmesis will be bad, maybe radiation will be difficult. But in this girl who is just 36 years old, obese, having a very good sized double D cup breast, a simple, you know, sort of a neoadjuvant chemotherapy, she was HER2 positive. She responded very well to neoadjuvant. You can see a pre-neoadjuvant picture over there, and then a post-neoadjuvant, and simple, you know, cordentectomy. I kept my ultrasound with me to have a proper visualization of wires so that I won't excise that much. Simple type 1 oncoplastic procedure in her case, saved her breast, and then followed by radiation. So every time you don't need to do the fancy things with the partial reconstructive things, you just have to do your precision planning, and that's it. Again, a lady who is having multifocal breast cancers, post-neoadjuvant, and here you can see 2 clips are placed. You ask your radiologist to precisely pass wires, and precisely with the help of intraoperative ultrasound, or smaller tissue piece can be excised with the negative margins. Now come to the breast cancers having invasive component with lot of DCIS. If you can visualize over here, these are microcalcifications with multiple lager clip placed. These lesions were appreciated on an ultrasound and on a contrast enhanced mammogram, and that was showing DCIS with an invasive component. Young girl recently got married when she discovered this breast cancer. Very interested to have a breast conservation, but unfortunately, as Dr. Asghar mentioned, she had been to one of the surgeon in her vicinity, and he performed a lumpectomy, and she presented to me post-lumpectomy, and that lumpectomy thing was showing invasive carcinoma with all positive margins. So this is post-lumpectomy. She had given neoadjuvant, she was HER2 positive, dual blockade was given. She responded very well, and without, you know, doing a fancy thing with the same scar, obviously she has a very good sized breast with a good amount of dense breast tissue. The entire area was excised with multiple wires, that's called bracketing, and breast was conserved. 3 years down the road, no recurrences. Now come to the patients who have a smaller size breast, but obviously they are interested to have breast conservation, and you think about volume replacement techniques so that you can conserve her breast. This lady, post-neoadjuvant, there were 2 tumors. One tumor was marked over here, and there was another tumor periareolar. This tumor didn't respond to neoadjuvant, however, this area had responded. Simply doing a Leica flap, just excise that area with the help of bracketing, and excuse me, please don't take pictures. I haven't taken that much liberty from patients, ethical liberty, that you can take pictures. So Leica flap was performed, and she had a very good cosmetic outcome. Radiation she received, and no recurrence. Again, a lady, as I said, age is not a barrier for breast conservation, so don't think about कि भाई ये तो 40 की हो गई, 50 की हो गई, अम्मा हो गई. No, this is not the case. Every woman has a right to conserve her breast if it's possible. 54-year-old lady, very interested, received neoadjuvant, didn't respond. As usual, hormone positive, they didn't respond to neoadjuvant that much. So in her case, there was a puckering of the skin also, where tumor was very close to the skin, and in her case, the tumor was excised with the L-tap flap, that is a different pedicle flap. With a skin pedicle, the puckered area of the skin was removed, as I discussed preoperatively with the radiation oncologist, and he of the opinion that please remove that portion of the skin also, because we don't know whether this is an involved skin or it's just because of corpus ligament infiltration. So she had a skin pedal also over at that point, and obviously she had a negative margins with no skin involvement. with no recurrences down the road. I think it's been like 4 years that I performed this procedure. Mucinous carcinoma, as usual, they don't respond to neoadjuvant, but when they present it with the bigger tumor sizes, obviously, and when they are nulliparous young ladies, they really want to conserve her breast. Neoadjuvant given, expected, she didn't respond. Flap was performed with a good cosmetic outcome. And then you have patients who have, papillary, in situ papillary lesions. Usually they present with a very big disease most of the time. Kabhi 4 centimeter, kabhi 5 centimeter. When you performed a biopsy, you found papillary in situ disease, and they are not going to respond to neoadjuvant as an in situ phenomena. So simply, in her scenario, I-cap anti-intercostal artery perforative flap was performed for volume replacement with a good cosmetic outcome. Again, young ladies didn't respond to neoadjuvant metaplastic carcinoma, known for not responding to neoadjuvant. Actually, she progressed. So the breast was conserved, and obviously a bigger recession was required in this area. So latissimus dorsi were placed as a volume replacer with a skin paddle with a good cosmetic outcome, alhamdulillah. Solid cum cystic mass, neoadjuvant chemotherapy didn't respond. Interested in breast conservation, breast volume replacement was performed with the help of latissimus dorsi, and a much bigger section with the negative margins you can attain without removing the breast. Now come to the scenarios when you have a patients who have multifocal disease or a multicentric breast cancer, having a totic huge breast, and they really want to downsize their breast also. Here you can do a reduction mammoplasty in the bilateral side, attaining a good cosmetic outcome. You can reduce their breast size and get negative margins without doing any volume replacement or replacement. This lady is having a multicentric breast cancer. Actually, she had a breast tumor. She had actually reduction mammoplasty followed by fed grafting, and then she had complications, and after 4 months of all that process, she was discovered with multicentric breast cancer. She was extremely interested, very keen about, about her body image, and extremely interested to have breast conservation. Unfortunately, the tumor was luminal type breast cancer, and we know that they don't respond to that much to neoadjuvant thing. So in her scenario, there was a tumor in the lateral side of the breast, in the lateral quadrant of breast, and one tumor foci was at 12 o'clock somewhat in the near quadrant. Simply I did wider excision with the help of bracketing and with the help of radiologist input. Perioperatively, ultrasound was capped to see that tumor precisely and precisely excise that area without doing much volume replacement. It was just a volume replacement in her case because she already had lot of breast thing, that's breast reduction mammoplasty and fed grafting. And then in this scenario, if you excise too much, or if you resect too much, or dissect too much, or raise too much breast tissue, she can caught up with fat necrosis. So that disease was excised with a negative margins, and it's 2 years down the road. Again, you can see you have patients when they have calcification extending up to the nipple most of the time, even to date. When we explain to patients about the microcalcification thing, that it could be a DCIS, and obviously for known reasons, it's difficult for a radiologist to perform a stereotactic biopsy of a calcification which is very close to nipple because of technical reasons. She was very interested to conserve her breast, and what we have done, obviously we bracket that area, and the nipple area was sent for frozen preoperatively to see if these calcifications are DCIS or not, and that was negative. So the breast was conserved, and the volume replacement was performed with a pedicle flap. So that's how it is. Last but not the least, this is also an important thing in our part of the world, phylloides tumor. This is not something unknown. I'm sure those who are breast surgeons, they must be treating a lot of phylloides tumors apart from breast cancer. This is a phylloides tumor, what has been done by, actually the husband was a pharmacist, and what he has done, when he saw a big cystic component under the skin, he thought it's an abscess. So he said, start applying magnesium sulfate and this will come out, this abscess will come out. So she applied actually magnesium sulfate for 2 weeks, and continuously fluid was oozing out from that area, and then she identified that some gooey material is coming out, which alerted her. So when she presented to me, I told her this is a phyllodes tumor upfront. We'll get a histopathological diagnosis. But obviously that was not an abscess and your husband actually applied the wrong thing over it. Obviously a young lady interested in breast conservation, so the phyllodes was excised and latissimus dorsi flap was performed to attend the cosmesis. So if you have a bigger phyllodes tumors, yes, you can use your innovative reconstructive things to attend cosmesis and to attend breast conservation. Recurrent phyllodes tumor of the breast, young girl, you can see from her age, had multiple times recurrences of initially it was a benign, then borderline, unmarried, then got married in that entire period, interested in breast conservation. So breast again was conserved even with a good cosmesis with a LICA flap, and then in her scenario, because she was recurrent borderlines, it was discussed in tumor board before I move forward with my surgical procedure, and we decided we are going to radiate her and we are going to treat her like a sarcoma case. It's like now it's 3 years down the road, she didn't recur yet. Initially, over 1.5 year period, she was recurring again and again with the phyllodes tumor. So yes, you can use your reconstructive things also for, correcting the deformities. This lady, 70 years old, and she was interested to correct her deformity. That was actually her primary breast surgery was performed 20 years back. And she was like, whenever I saw myself in front of mirror, I feel, really depressed and dejected, and I don't want to see my breast in that manner. So age is not a bar for anything. If they're interested, if they're willing, if they are fit, they have a right to get a good quality of life. So when we talk about partial breast reconstructions, we always talk about contralateral breast. And I learned from my mentor, Werner Aldrich, that for our part of the world, none is best. Proposed procedures which do not require contralateral symmetrization, because obvious reasons, patients do not have that much finances. They don't want to undergo contralateral surgeries because we do not have insurance plans or the backup plans which can cover their surgical procedures. So whenever you plan your surgical thing, always think about that you try to not give a plan that requires contralateral symmetrizations. Whenever you plan your procedure, always keep in mind if something got wrong. If it's a partial, you may need extended partial. May you need mastectomy and reconstructions, and may you need to manage the opposite breast. So whenever you are doing a surgical planning, whenever you are giving incisions, keep in mind that might be because of positive margins, maybe because of other reasons, you might need to have another surgery. And obviously, with that reference, give your surgical incisions. That's our paper we published in 2023 when I started my oncoplastic thing. I started probably in 2016 when I came back from my oncoplastic fellowship. And then we start collecting data on reconstructions and oncoplastic thing, and we published this paper on quality of life. This is the first paper from Pakistan addressing quality of life in partial mastectomy versus mastectomy or a breast conservation. Obviously, recently we published another paper. This is about extreme oncoplasty, when we offer these procedures for those ladies who have multifocal, multicentric, and we are removing a bigger chunk of area of breast tissue. We published our data in terms of margins, in terms of cosmesis, and in terms of recurrences. And many times, when I present my data in different meetings, most of the surgeons question me, आप बहुत बड़ी रिसेक्शन करती होंगी, margins 4-4 सेंटीमीटर की निकलती हैं, तो नेगेटिव ही आ जाती हैं. So you can see here, down there, the average was 0.68. So even if you're doing your precision planning with the help of your radiologist, radiation oncologist, pathologist, and your perioperative ultrasound, obviously, you don't need to go for a very wider margins. Okay, so what I learned over years, breast conservation is gender neutral need. I have patients who are male and who do not want to have a mastectomy if they diagnosed with breast cancer or papillary lesions. They also want to have a breast conservation. They want to retain their nipple area complex also. So it's a gender neutral need. Don't think about male hai to bas निकाल ही देंगे, कोई मसला नहीं है, इसका क्या है? Obviously, a diverse population, you have a diverse mindset. There are patients who understand very well. There are patients who do not understand your conversation, and then you have to call their attendants, and sometimes you have to do several meetings with them to counsel in that context. Patient inclusivity is very important. ये ना करें, attendants को समझा दिया और बस सही है मेरी मर्जी मैं जो करूं. It's important she should understand how it's going to be in post-op and how it's going to be after 2 years or 5 years. Equity is important. मेरे पास चाहे मेरा patient educated background से हो या uneducated background से हो, this is my duty, this is your duty, that you should offer them standard care. Don't think about she is from Gharo or from Chagi, mastectomy कर देते हैं इसकी. No. Everybody has the right for a standard treatment. Question your status quo. If you're not changing your skills, if you're not changing over years, if you're same mastectomy surgeon or same lumpectomy surgeon, then question your status quo. There are complications, so always think about that complications, your complications, keep in mind, record that complications and learn from your complications. That's my fellows. I'm very happy now that I have many breast surgery fellows, which I and Dr. Shaista trained, who are doing oncoplastic surgery in their capacity, maybe level 1 oncoplastic procedures, wherever they are working, either they are at Cancer Foundation or Patel Hospital. Safna is a new fellow, Safna is sitting over here. So Tarbiya was my observer. She went to US. Alhamdulillah, she got a breast surgery fellowship over there with a renowned breast surgeon. So that's how you learn and you pass your skills to your juniors. That's a take-home message. In the art of surgery, the last part is operation. So always do a better planning before you decide any surgical procedure or technique. Thank you very much. ये मेरे वो patients हैं, they always want to keep their pictures in my talk. Those who had breast conservation, and they're very happy. Thank you so much.
Thank you very much, Dr. Vohra. You truly said that we have to proper plan with the multidisciplinary team. We should not give surprises. And of course, if we give surprise, we will get surprise. So thank you very much. During the talk, Professor Asghar raised a question from Madam Shaista Khan. So I would request Madam to please answer that question. Ji, Madam Shaista.
Thank you very much for giving me the honor of chairing this session where our esteemed speakers have addressed an issue that is worldwide a problem. So breast cancer continues to remain the commonest cancer in females. And Pakistan is not behind in terms of figures, but as far as mortality is concerned, we exceed those numbers. I'll take Dr. Asghar's question first, and he had asked if it makes a difference who's operating on the axilla. Am I right? Okay. It's important to understand the anatomy of the axilla. Where does the lymphatic drainage come to the axilla? It's not exclusively the breast, it's the arm. And what we have to do is avoid removing the lymph nodes that are draining the arm. So your understanding of anatomy of the axilla is important. And if doing a complete axillary clearance that is being undertaken by a person who's doing a mastectomy is a disservice. So operating on the axilla has to be done by experts who are knowledgeable about the anatomy of the axilla, and if only we could identify very accurately which are the lymph nodes that are coming from the arm, and we avoid those. Even reverse axillary mapping technique has not helped us that much. So it is important to be properly trained in doing surgery on the axilla, and we hope that now ablative axillary surgery is going to be minimized. And we will end up by understanding that surgery on the breast is a different intention and objective, and surgery on the axilla is different. They don't go together. So even though we may be doing mastectomies, we are trying to save the axillary nodes. Commonly we think that the level 1 lymph nodes from the breast, which are below the axillary vein and lateral to the lateral border of pectoralis minor, are the commonest ones that are draining the axilla, the breast. And the ones that are next to the thoracodorsal pedicle, and especially to the lateral side of it, probably are the ones that are draining the arm, but that's no guarantee. See, level 2 lymph nodes, when should they be removed? When you are doing a therapeutic axillary clearance. So for the therapeutic axillary clearance, nowadays we are not doing level 3 clearance. So up to level 2, and therefore this is again an escalation, level 1, level 2, the pedicle, the lat dorsal pedicle lymph nodes are not part of level 1 or level 2. And therefore they should be spared if possible. But we know quite frequently we find intraoperatively they are involved.
No, madam, literature says that at least should be at least 10 lymph node must be removed from the axilla to say it is adequate axillary dissection. But do you think that all these 10 node can be from level 1 alone?
See, the pendulum has swung back. When did we think about doing conservative diagnostic or staging procedure of the axilla to see whether the lymph nodes are involved or not? This was back in 1980s and early 1990s when Veronesi's group had started what was called axillary node sampling, which meant for adequate staging of disease in the axilla, at least 4 lymph nodes have to be removed from level 1. So we talk about, learning how to do sentinel lymph node biopsy. One has also got to learn how to do axillary node sampling from the correct level of the required number of lymph nodes. When we talk about axillary dissection, and you mean axillary clearance, in the age group under 60, if you're doing adequate clearance, the number of lymph nodes that have to be retrieved should be in double digits. If you removed 8 lymph nodes and say, I have done axillary clearance, you have done axillary node sampling.
Madam, sorry, one more question. I'm sorry, I'm taking your time. Now the guideline also say like this, that when the clinical node positive and now after this neoadjuvant chemotherapy node is inactive, omit the axilla, but they then say that consider radiation to the unaddressed axilla. In my understanding, unaddressed axilla is the level 3 and the supraclav. What do you think when the level 1 and level 2 is clear, then we should take level 3 and supraclav in our radiation field?
If you can just give me a few minutes.
No, madam, it's okay.
May I ask in the audience, how many are students over here?
Students, raise your hands, please.
Okay. How many are doing their residency training?
residents, yes, please raise your hands.
And how many of you have a passion for breast surgery? So, as a passionate breast surgeon, you are not a single-digit family. The family includes the oncologist, the radiation therapist. You don't work in silos. You don't work in a hospital and say, I have removed this lesion, move on and go on for your further treatment. Now, today's talk, and I think, Asghar, I'll just answer your question. We heard about the axilla. Yes? So what group of patients are we talking about when we had such an elaborate presentation by Professor Rufina? Which patient group are we talking about?
Very early.
The dividing line here is mastectomy versus breast conservation. Okay? So these studies are not applicable to patients who are undergoing mastectomy because we are heavily depending on radiation. And the principle is early breast cancer. So when you ask about the lymph nodes up here, supraclavicular, the dividing line here is not early breast cancer. Early breast cancer has to be T1, T2, N0, N1, not N3. So if we are talking about unaddressed nodes, we are exclusively talking about advanced disease.
Agreed. So we can safely omit the level 3 and level supraclav when it's an early lesion and it was a clinically or pathologically node positive disease, and that was only sentinel node positive, and that has been taken out, and you are omitting the surgical dissection of axilla, then why to radiate them at the level 3 and level supraclav?
All these questions are so valid, so valid. When do you think these questions should be put?
When it's an LABC.
In the MDT. In the MDT. So who is the beneficiary of MDT? The patient or the doctors?
Patient.
No. It's the healthcare providers who are benefiting from the MDT, not the patients. Yes, of course. These questions are to be put in the MDT. So you know exactly. And the basic question is, 2 questions about axilla. Does this axilla have disease or not? First question, is there disease in the axilla or not? If the answer is no, whether we apply the sound trial, whether we do the sentinel node biopsy in upfront surgery, there is no disease in the axilla. So the second question is, does the axillary disease require treatment? And if there is disease, then the answer is yes. The disease in the axilla requires treatment. And what are the 2 ways of treating disease in the axilla? Surgery or radiotherapy or both. Both will only come in advanced disease. Early disease, either surgery or radiation. And now, as I said, the pendulum has swung back. In the late 80s and 90s, if on axillary node sampling, you found positive nodes, the disease was treated with radiation. We are coming back to the same point now. We are doing microsurgery by picking disease via sentinel lymph node, and we are saying, yes, radiation will take care of it. And that is why it's important that most of the breast surgeons here, I assume, are doing mastectomies, am I right?
Yeah.
So please, the take-home message is management of axilla with mastectomy is different versus managing the axilla in conserving the breast is different. So I would just like to end by saying that we are all almost, in a state of anxiety as healthcare providers for the women's health in Pakistan. The two risks that I see in women's health is, of course, reproductive health, maternal mortality. That is perhaps being taken care of or is being addressed. But breast cancer, that is I would say the leading hazard, health hazard, has not been taken up. It could be the policymakers, but at least we stand up right now that we have come up with the help of and contribution of many. The fellowship program in breast surgery is now well established. So we are having graduates coming out, fellows in breast surgery, who now need to be accommodated in appropriate institutions. And the need now is that in most of the places, and I would say public hospitals, is there a dedicated breast surgeon or not? A position needs to be created because there are several breast fellows who are coming out, and I must say the program is strong, and these fellows are being accepted abroad. Why are they being accepted abroad? Because of the quality of training that they have received and the certification level that they have received, that they are being offered jobs elsewhere. So there is a need now in the government institutions that there are proper budgeted positions for these fellows who can offer the best and the correct tailored management of breast cancer.
Thank you very much, madam, for that comprehensive answer. With that, we conclude our session, and I would invite you, if you want to address our audience, please come here and address the audience, say a few words.
I think I've said too many words. It doesn't matter.
That was the answer to the query.
No, I think
it's okay. Thank you very much. And now I would like to come Dr. Mariam.
Okay, so let's proceed further. I would like to call upon stage Professor Dr. Farhad Jalil. She is a professor and the head of breast surgery at Dow University of Health Sciences. Her unparalleled contributions to the field of surgery and medical education have set a standard of excellence. Please welcome Professor Dr. Farhad Jalil. Now, I would like to welcome Professor Dr. Shaista Khan on stage to receive her award. Thank you so much, Dr. Shaista, for joining us today. Thank you so much, Dr. Zareen. Please give a big round of applause. Now I would like Professor Dr. Shaista Khan to give her award to Professor Dr. Farhad Jalil. Professor Dr. Shaista, I would request you to stay on stage for further distribution of the award. Now, I would like to call Professor Ahmed Nadeem Abbasi, a renowned expert, I must say, to receive his award. Please give him a big round of applause. Thank you so much, sir. Okay, now I would like to call Professor Asghar Hussain to come on stage and receive your award. Please give him a big round of applause. Thank you so much, sir, for joining us today. Dr. Lubna Vohra, please come on stage to receive your award. Thank you so much, Dr. Lubna, for coming today. Now I would like to call Dr. Rufina, the esteemed professor of surgery at Liaquat National Hospital. Okay, Dr. Zareen will receive the award of Dr. Rufina, as she is not here. Please give a big round of applause. Okay, now I would like to welcome Dr. Sayyida Zareen Raza, a renowned specialist in breast surgery, whose expertise, okay, you have received it already. Okay, thank you so much for your time. Jazakallah.